Without further ado, patient-centered care updates of management of early stage breast cancer with Dr. Yara Abdou, MD. Dr. Abdou, welcome. We're so glad to have you here today.
Thank you, Tim. Hello, everyone. I'm Yara Abdou. I'm a breast medical oncologist at University of North Carolina in Chapel Hill, and I'm very excited to be here with you all today. I apologize in advance for my raspy voice. I'm getting over a cold, but nonetheless, I'm excited to talk to you about breast cancer today and about our recent updates for the management of early stage breast cancer.
Well, we are very glad to have you here. I'm afraid our audience will have to deal with both of our raspy voices because my allergies are just hitting. So let's see. We've got a few highlights that we've noted about you. That you're an assistant professor at the University of North Carolina, Chapel Hill, and a breast cancer oncologist at the Lineberger Comprehensive Cancer Center. We've also noted that you specialize in the treatment of early stage and metastatic breast cancer, and your research focuses on the development of novel therapies and investigating innovative biomarkers of disease recurrence and treatment response. As a clinician and researcher, your goal is to improve treatment strategies for breast cancer patients while minimizing suffering and morbidity from the disease, and that you are dedicated to improving disparities and promoting diversity in clinical research to deliver equitable care to all patients, regardless of race or ethnicity. And what's one thing we might add to that outside of that more professional realm, interest or a hobby or something along those lines?
Well, I have an 18-month-old son who's keeping me on my toes right now and
Oh
getting
my
me all
gosh.
those daycare bugs that I absolutely love.
Oh my gosh. Yeah, I remember that. Well, good for you. Yeah, 18 months. That's a lot of fun.
Yep, he is. He
Yeah.
is. Absolutely so much fun.
Oh my gosh. Well, I mentioned that poll everywhere question, and the one that'll pop up if it hasn't already. In the United States, breast cancer is the most commonly diagnosed female cancer, and and actually I think we actually switched that up a little bit, but don't worry about that. You'll see that in a moment. There are disclosures. So I said that, but I'm going to give you a different question. So early detection and management of breast cancer is important for improving survival rates and quality of life. This is always kind of a softball, this first one, just so anyone who hasn't used Poll Everywhere before can go ahead and see how that works. We can see the percentages. Seems like we've got a strong trend going in one direction, Dr. Abdou. How are
I
they
don't think
doing?
you need me here, Tim.
No, we need you. The questions are going to get harder, so we definitely need you. But so hopefully you've got the hang of Poll Everywhere for our audience. Without further ado, updates on management of early stage breast cancer with Dr. Abdou. Dr. Abdou, I'll let you take it away. Thank you.
All right. Thank you, Tim. All right, let's get started. So these are my disclosures. So as an overview, I would like to talk about the epidemiology of breast cancer and risk factors associated with the disease. Then we're going to review updated screening guidelines and modalities for breast cancer. And then from there, we're going to move to breast cancer staging, latest treatment strategies for early breast cancer based on each specific subtype. And then lastly, we're going to review some guidelines for breast cancer surveillance. All right, this is the question you guys answered. This is absolutely true. In the United States, breast cancer remains the most commonly diagnosed female cancer, with more than 300,000 cases being estimated this year. It is the second most common cause of cancer death in women in the United States, and it's actually the leading cause of cancer death in less developed countries. So this bar graph really shows you where the majority of our new cases by age group occur. So as you see here, female cancer, breast cancer is most frequently diagnosed among women aged 55 to 65, and the median age at diagnosis is about 62 years old. But it's important not to forget that breast cancer can occur at any age, even younger age. So we do have younger females and older females who are diagnosed with breast cancer. Also important to remember is that men can get breast cancer too. About 1% of breast cancer cases occur in males. 1 in 833 men in the US develop breast cancer in their lifetime. And in 2024, there's an estimated 2,800 new cases of invasive breast cancer to be diagnosed in the US. So as you see from this figure, while the number of new breast cancer cases has been relatively stable over time, and that's represented in the line on the top, on the line on the bottom shows you the death rate, and the deaths due to breast cancer has been steadily declining. And this is really mainly due to a combination of earlier detection. So shout out to all our primary care providers who are ordering screening mammograms on time, and to improvements in therapy over time. So we've had major advances in the treatment of breast cancer. Overall, the 5-year relative survival for all comers with breast cancer is nearly 90%. So it's great when we look at that 90% number. However, metastatic breast cancer remains incurable, and it's one of the leading causes of cancer-related mortality. So while a lot of the early stage breast cancers are curable and they have a good 5-year relative survival, there's a lot of cancer that's has spread and not curable. So it's important for us to diagnose the cancer early and to be able to treat it appropriately. So this also emphasizes that same point. It's a general rule that when cancer is found early, people do well. And when cancer is found late with a larger burden of disease, people unfortunately don't do as well. So again, emphasizing the importance of early detection and treatment to improve survival in breast cancer patients. So let's move on to talking about risk factors for breast cancer. So I would like to start with a question here. So only women with a family history of breast cancer are at risk of developing the disease. True or false? All right, looks like everybody is committed to false at this point, which is correct. And we'll talk about risk factors in a second. So while family history of breast cancer can increase the risk of breast cancer, there are many, many other factors that contribute to the risk of developing breast cancer, which we'll talk about in a second. So let's start with demographic risk factors. So age, everybody knows this. We showed it in the previous slide. The older you are, the higher the risk of breast cancer, with a median age in the 60s. Female sex, right? There's more breast tissue in females, so female sex has a higher is a risk factor for breast cancer. White race, so in the United States, the highest incidence of rate of breast cancer occurs in white women. However, I do want to emphasize that Black women are disproportionately affected by more aggressive subtypes of breast cancer and are more likely to be diagnosed with more advanced stages of the disease. In fact, breast cancer death rates are 40% higher among Black women than white women. That's why it's an important focus of my research, because it's important for us to recognize these disparities in order to identify strategies to overcome them and close this horrendous mortality gap. Moving on to hormonal risk factor. So menopausal hormonal therapy. I'm sure a lot of you have heard of this. The long-term use of hormone therapy for menopausal women has been associated with a higher risk of breast cancer. The number 5 years has been, so if you're on hormonal therapy for over 5 years, there's an increased risk of breast cancer there. And then there are other reproductive factors, so such as early menarche, later menopause. So you're exposed to estrogen for a longer duration of time in your lifetime. Nulliparous women, so not having kids, or an increased age at the first pregnancy, so becoming pregnant over the age of 35. has been associated with an increased risk of breast cancer. And it's again associated with the increased exposure to hormones. Moving to the next set of risk factors. So these are your modifiable risk factors. So weight and body fat. A higher BMI has been associated with a high risk of breast cancer. Alcohol use and smoking has been moderately associated with an increased risk of breast cancer. Exposure to therapeutic ionizing radiation. So sometimes there are patients who have other cancers at a young age, such as Hodgkin's lymphoma. And in those cancers, we have to radiate the chest. And exposing the chest to radiation can increase your risk of breast cancer. And you can also get exposed to ionizing radiation through nuclear plant accidents, or survivors of atomic bombs can also have an increased risk of ionizing radiation. Last but not least, the family history and inherited risk factors. So any family history of breast cancer increases the risk of breast cancer, regardless of whether you find any inherited genetic mutations or not. And then you have the specific inherited genetic mutations. Those significantly increase your risk of breast cancer. However, those mutations are pretty rare. So only 5 to 6% of breast cancers are directly attributable to inherited breast cancer susceptibility genes. But once you have those, if you have those genes, then your risk of breast cancer is pretty high, and we'll talk about it in a few slides. Breast density is also associated with a high risk of breast cancer. So women with mammographically dense breasts have been shown to have 4 to 5 times higher risk of breast cancer compared to women of similar age with less dense breasts. And I clumped that into family history and inherited risk because breast density is a feature you inherit. Usually you inherit from your family. All right, moving on to hereditary breast cancer. So I just wanted to touch base a little bit on the genes most commonly affected with breast cancer. And as you see here, these are the most commonly associated genes. I'm sure many of you are familiar with BRCA1 and BRCA2. Those have the highest breast cancer risk at about 70%. Then you have PALB2, which has a 53% breast cancer risk. And then you have CHEK2 and ATM, which have a moderate increased breast cancer risk of about 20 to 30% in comparison to the general population, which is about 12% risk in their lifetime. All right, so I'm just noticing this typo. It's supposed to be BRCA1 and BRCA2 associated cancers. So in women, that's breast cancer and ovarian cancer. So if you have the BRCA mutation, then you are more susceptible to breast cancer and ovarian cancer in women. In men, it's an increased risk of breast cancer and prostate cancer. And in both men and women, you can see an increased risk of pancreatic cancer and melanoma. So why is it really important to know of hereditary genes? One, it's because we have targeted therapies. So now we have therapies specifically for patients with BRCA mutation. So if you have that hereditary gene, we can treat you with a specific type of drug, and we'll talk about this a little later today. And then you can have risk reduction surgeries to reduce your risk of breast cancer, like Angelina Jolie, who had a prophylactic double mastectomy to decrease her risk of developing breast cancer because she has a hereditary gene that increases her risk for breast cancer. Then it helps you also have a more personalized screening algorithm. So for patients who have a higher risk of developing breast cancer because of their hereditary genes, we might develop a more personalized screening mechanism, such as MRIs and ultrasounds in addition to their mammograms. Then it also helps you discuss that risk with your family and increase awareness amongst your family members. All right, so let's talk a little bit about breast cancer screening. So different groups recommend sort of a little different guideline algorithm, but it looks like all groups agree that at least by the age of 50, you should be getting a screening mammogram, at least yearly or every 2 years. And that should continue for at least the age of 75. The American Cancer Society has one of the most aggressive guidelines for breast cancer screening, which is what I tend to recommend for my patients, which is starting at the age of 45 and continuing breast cancer screening with no age limit, as long as the patient is healthy and has a life expectancy of over 10 years. So why do we do screening mammograms? We know from studies and literature that women who get regular screening mammograms cut their risk of dying from breast cancer by about half. We also know that women who have screen-detected cancers have less extensive surgery for their cancer because we detect it at a earlier stage, and the tumor would be a smaller size. We also know that less chemotherapy is given for women with screen-detected cancers and more effective treatment overall. So how do we usually screen? It's usually a mammogram, which is a low-dose X-ray of your breast tissue. I wanted to touch base on two main types of mammograms, which is the 2D mammography, and more recently, we're hearing more of the 3D mammograms or breast tomosynthesis, which I would like to talk to you a little more about. So this is an example of a 2D mammogram. So a 2D digital mammogram usually involves at least 2 pictures of each breast taken at different angles, typically from top to bottom and from side to side, and provides a 2-dimensional view of the breast. A 3D mammogram is a newer type of mammogram in which the machine takes several low-dose X-rays as it moves in an arch over your breast. And then what happens is that the computer puts all these images together, allowing us to see breast tissues more clearly in 3 dimensions. There are many studies that have looked at 3D mammograms showing that it increases cancer detection, including detection of lower grade cancers, and decreases false positive rates. So a 3D mammogram here is particularly advantageous for women with denser breast tissue. So this is, sorry, I forgot to click on the slide. So this is a picture of a fatty breast tissue on the left and denser breast tissue on the right. So 3D mammograms are particularly advantageous for women with denser breast tissue because dense breast tissue typically has a higher proportion of glandular structures. So in an X-ray image, this fatty tissue can look gray, but the glandular tissue looks white. And most cancerous tissue also is white. So when you have a lot of glandular tissue in dense breasts, you can miss those cancerous tissues. As you see here, I circled the cancerous tissue in both the fatty breast and the dense breast tissue. And as you see on the right, it's really harder to pick up that cancerous tissue in the dense breast. So this is an example of a 2D and a 3D mammogram with denser breasts. So the 3D mammogram is really more ideal because it allows the radiologist to look at the tissue layer by layer, and it helps us distinguish between glandular and malignant structures in a more straightforward way. So you can easily see here in the 3D mammogram that cancerous tissue circled in pink is more easily picked up on the 3D mammogram rather than the 2D mammogram. So there hasn't been head-to-head studies comparing 2D mammograms with 3D mammograms. There have been a lot of studies showing that 3D mammograms are really helpful, specifically in denser breast tissues, but they haven't compared them head-to-head to 2D mammograms. So this is a study that's actually comparing them head-to-head, and UNC is participating in that study. So I believe if you contact the research coordinator, you're able to enroll on that study here at UNC. All All right, so mammograms can help us detect cancers, but they can't really diagnose the cancer. So while mammograms show us the abnormal tissue, to prove that this abnormal area is actually breast cancer, you need a biopsy. So what happens is, for example, if you send 100 women to get a screening mammogram, 90 will come back with a normal mammogram, 10 will return for additional imaging. 6 of those will probably be reassured that their additional imaging is normal. 2 may be asked to return in 6 months for a follow-up exam, and then 2 will have a very highly suspicious lesion that will recommend a needle biopsy. So a breast biopsy is the only way to actually tell that this is cancer for sure versus something else. So moving on to an actual case. So this is Miss K. She's a 55-year-old woman with no prior comorbidities. She went to have her screening mammogram and was found to have a 1.4 centimeter left breast mass. She has no axillary lymph nodes palpated on exam. They did an ultrasound, which was negative for enlarged lymph nodes as well. So what is your next step? So like we showed in the previous slide, we saw an abnormal mass on imaging. The next step would be to biopsy that mass. And the reason we do that is because we want to actually confirm she has breast cancer. But the other most important thing in breast cancer is to determine what the actual breast cancer subtype is. So breast cancer is not one disease. It's a very heterogeneous disease, and it's classified into different subtypes. And I'll show you in a second how we determine those subtypes. But the big groups of the big subtypes of breast cancer, or the 3 big categories of breast cancer, are hormone positive. And that's the majority subtype, which constitutes about 60 to 80% of all breast cancers. Then you have the HER2 positive breast cancer, which is about 15 to 20% of all breast cancers. And then you have the triple negative breast cancer, which is about 15% of breast cancers. So how do we determine that is when we actually take the breast cancer cell out during a biopsy or surgery. We look under the microscope and we look for 3 specific proteins or receptors on the cells of the breast cancer cell. And these 3 proteins that we're looking at are ER, which stands for estrogen, PR, which stands for progesterone, and HER2, which stands for HER2 protein. So the breast cancer cells may have some of these receptors, all of these receptors, or none of these receptors. So if we have and we identify the estrogen and progesterone receptor, then we call that hormone positive breast cancer. If we find the HER2 protein on the surface of the cell, we call that HER2 positive breast cancer. If we don't find any of these receptors, so none of these receptors, as you see on the image on the right, are present on the breast cancer cell, then we call that triple negative breast cancer. And it's really triple negative based on not finding those 3 specific receptors that we're looking at. All right, so let's move on to breast cancer staging, which is another important evaluation that we consider when a patient is diagnosed with early stage breast cancer. So the way we do staging is using something called a TNM staging system. So T stands for the primary tumor size, N stands for the regional lymph nodes involved, and M stands for distant metastases. You get a score for each of these letters. So T, the larger your tumor, the higher is your score. So T1 is a small tumor that's less than 2 centimeters, whereas T4 is a large tumor that's invading the chest wall. Similarly, N stands for lymph nodes. The number of lymph nodes involved in the axilla or the clavicular lymph nodes, the higher the score you get for your N staging. And once we, I'm actually going to jump 2 more slides to show you a picture here. So the stage that you get is actually based on the TNM score. So after you plug in your TNM scoring system, you get a particular stage, as you see on the table on the left. The higher your TNM score, the higher is your stage, and the higher is your stage, the worse is your survival, as you see on the right. So that also emphasizes that catching the cancer early is important for treating the cancer appropriately and improving survival. Scrolling back, I wanted to show you this, which is an easy way of sort of dividing stage into two big broad categories. So we can divide stages to 1, 2, 3, clump them all into local regional breast cancer. And this usually is breast cancer that is only in the breast and the lymph nodes and has not spread to outside parts of the body. And we consider that non-metastatic and curable. And then the other part is the stage 4 disease, which is the metastatic breast cancer that has spread outside of the breast and the lymph nodes. Usually that is not curable disease. So about 5 to 6% of women with breast cancer have distant metastasis at the time of their first diagnosis in the US. Breast cancer can go to many different parts of the body. The most common sites are the bones, the lungs, and the liver. Breast cancer can also go to the brain, as you see here in the image in the center. It's more commonly associated with brain mets in triple-negative breast cancer and HER2-positive breast cancer, which tend to be more aggressive subtypes of breast cancer in general. Right? Talked about this slide. So I wanted to also show this slide to circle back to subtypes. So staging is not the only factor that really determines survival. As you see here on the top, this is a patient with stage T2N0 breast cancer. If you look at the survival in a patient with T2N0 breast cancer that has hormone-positive HER2-negative breast cancer, it's about 96%, whereas a patient in the same stage that has triple-negative breast cancer has a survival rate of 88%. Similarly, a stage 4 breast cancer patient can have a survival rate of 47% if it belongs to the hormone-positive HER2-negative subgroup and a 17% survival rate if it belonged to the triple-negative breast cancer subgroup. So the subtype of breast cancer is very important, and that's what I want to emphasize from this slide. So right now, the new staging system, which is the 8th edition of our staging system, it takes into consideration the biology of the breast cancer. So it takes into consideration the grade of the breast cancer and the subtype of the breast cancer. And that's how we actually give the patient a stage. And that gives us a better idea of risk stratification and management for our patients. So this is an example of how we stage patients. So first is the TNM scores, then the grade, HER2 status, ER status, PR status, and then considering all those factors, a patient is then given a stage for their breast cancer. So it's important to take into consideration the size and the receptors and the biology of the cancer itself. All right, so, excuse me. All right, so back to Mrs. K. So Mrs. K's tumor was biopsied and found to be invasive ductal carcinoma, grade 2. She had high estrogen receptors and progesterone receptors. 90% indicates that we found a lot of these receptors. So she has hormone-positive, HER2-negative breast cancer. She also was staged and found to have stage 1 breast cancer. And you discuss her case at multidisciplinary board, and the decision was to proceed with a surgery-first approach. All right, so I have another poll question for you here. Which of the following statements is true? Mastectomy is associated with a better chance of survival compared to lumpectomy. Survival after lumpectomy plus radiation is equivalent to survival after mastectomy. Or the risk of local recurrence is the same after mastectomy compared to lumpectomy. All right. So it looks like the majority of you are on the right track. Survival after lumpectomy plus radiation is equivalent to survival after mastectomy. And I'll show you some data here as we discuss breast cancer treatment and starting with local regional treatments. So this is the NSABP study. The NSABP study is an old study that really helped answer this question by comparing patients who actually received a mastectomy to patients who only got a lumpectomy with or without radiation. So there were two groups, mastectomy, lumpectomy alone, and lumpectomy plus radiation. And what this study showed is there were no significant differences observed amongst the three groups with respect to disease-free survival, distant disease-free survival, and overall survival. So survival after lumpectomy is equivalent to survival after mastectomy. When we look at the actual recurrence rate or the cumulative incidence of recurrence, we see that patients who had radiation treatment in addition to their lumpectomy had a 25% decreased risk of recurrence in comparison to women who had lumpectomy alone. So while survival wasn't different amongst those groups, you did see less recurrence in women who had radiation in addition to their lumpectomy. All right, so this is just tells you that your answer was correct. So survival after lumpectomy is equivalent to survival after lumpectomy. All right, so moving on to a different aspect of the surgical approach, which many of you are familiar with, which is the sentinel lymph node procedure. So sentinel lymph nodes are basically the first few lymph nodes in which a tumor drains. So when we say sentinel lymph node biopsy, it involves actually injecting a tracer material, either a radioactive substance or a dye into the tumor. And then the surgeon uses that special probe or device to locate the lymph nodes that contain the radioactive substance or dye. And the sentinel lymph nodes are the first lymph nodes that track the radioactive substance or dye. And those lymph nodes are removed by the surgeon and analyzed by the pathologist. And if these sentinel lymph nodes are free of cancer, then removing additional lymph nodes is not necessary. So right now, the morbid procedure of axillary lymph node dissection is not a standard approach because we have this sentinel lymph node biopsy procedure available. However, if your sentinel lymph node biopsy reveals cancer, historically that meant an immediate axillary lymph node dissection, removing all the rest of the lymph nodes. And the update to that I wanted to talk to you about is that in the modern era of breast-conserving surgery and adjuvant radiation therapy, do we really need to do axillary lymph node dissection for patients who have positive sentinel lymph nodes? And does that impact survival? And that question was actually answered in the Z11 trial that I wanted to show you here. Patients with 1 to 3 positive sentinel lymph nodes were randomized to receive a full axillary lymph node dissection versus no axillary lymph node dissection. And as you see here on the right, the graphs the lines are overlapping, suggesting that there was no difference in overall survival between both groups. And based on that study, actually, we do not perform routine axillary lymph node dissections for every woman who has positive sentinel lymph nodes if they meet the criteria, the Z11 criteria based on that study. And the criteria is that they had a breast lumpectomy and they're planning to have a radiation treatment to the breast area. They have a smaller tumor and that they didn't have large clinically positive tumors on exam. Lymph nodes involved on exam. So it was just an involved lymph nodes at the time of sentinel lymph node biopsy. And why is that important? It's important, especially for the primary care community, because this means that you're dealing less with lymphedema, which is a chronic and morbid complication that can result from axillary lymph node dissection. So less lymph node dissection, less lymphedema, definitely a win for everybody. All right, so for the sake of time, I'm going to briefly touch base on this slide. This is but just showing you the indications for radiation therapy in general for breast cancer. We don't recommend radiation therapy for everyone. Usually, as a rule of thumb, if you have lumpectomy and still have breast tissue, we recommend radiation to the whole breast. However, there are exceptions. Older women who have very low risk breast cancer can omit radiation therapy if they stick to their hormonal therapy. Usually radiation treatment is about 4 weeks, although it can extend to 5 to 6 weeks if you have a lot of lymph nodes involved. And then if you have your whole breast removed, we still recommend radiation treatment in certain situations where you have a very large tumor that's over 5 centimeters, or if you have other high-risk features or lymph nodes involved. All right, so moving on to breast cancer treatment in regards to systemic therapy. So I'm going back to Ms. K, who opted for a lumpectomy because we showed her that data of equivalent survival. She had a lumpectomy. Her tumor was excised. She had negative margins, and she had 2 sentinel lymph nodes removed that were negative as well. Her tumor size ended up being 1.8 centimeters, and she asks you, what are the next steps? So what is the rationale for systemic therapy? Systemic therapy, even though your cancer is out, really we treat systemically because we're going after those microscopic cells that are lingering there, waiting to grow and cause recurrence. And it's been shown from previous studies that patients who receive systemic therapy have a reduction in the recurrence of about 25 to 50%, and systemic therapy does improve survival in certain situations. There are many options for systemic therapy that will depend on your subtype of breast cancer, but options include chemotherapy, hormonal therapy, HER2 drug therapy, and the combinations of these. And now we have immune therapy for triple negative breast cancer that we're going to talk about in a minute. All right, so historically, not so long ago, we used to treat every tumor that's over 1 centimeter with chemotherapy. So the treatment was, okay, tumor is over a centimeter, chemotherapy is recommended. Nowadays, not so much. Excuse me. I apologize, that raspy voice needs some water. All right, so nowadays we've started understanding that breast cancer is not just one disease, right? It constitutes several distinct subtypes based on the proteins we talked about. However, within those subtypes, there are other distinct subtypes of breast cancer. And this is through actually the work of Chuck Peru here at UNC and many others. We have started understanding that breast cancers can express specific genes, and based on those genes they express, they can be categorized into different molecular subtypes. So in addition to categorizing breast cancer into those big 3 categories of hormone positive, HER2 positive, and triple negative, there are other molecular subtypes of breast cancer called luminal A, luminal B, HER2 enriched, and basal-like subtypes. And through this knowledge, we began to answer this important question of who really needs adjuvant chemotherapy, who needs more aggressive systemic therapy, and who doesn't. And why is this important? I wanted to show this slide because a woman with hormone-positive breast cancer, so this shows you patients with hormone-positive breast cancers, can have different relapse-free survival based on their molecular subtype. So within every big subtype of breast cancer, there are molecular subtypes that have different biology and therefore different prognosis and therefore different ways to manage these patients according to their prognosis. So luminal subtypes tend to have better prognosis than basal-like and HER2-enriched subtypes. So it's important to recognize these molecular subtypes in order to personalize the treatment approach for patients. So I'm gonna, this is basically reiterating our personalized approach to breast cancer. So let's dig a little deeper into the big subsets of breast cancer and how can we apply the personalized approach to treatment. So let's start with the hormone positive or ER positive subset of breast cancer. So which patients in hormone positive breast cancer should receive chemotherapy? So we now, in this era, we started personalizing treatment for breast cancer, particularly for hormone positive breast cancer, because that subtype of breast cancer, chemotherapy is not always indicated. And one of the ways we are personalizing care is through genomic assay testing, right? Because this really helps us find out which tumors are sensitive to chemotherapies and where benefits outweigh the risks of chemotherapies. And obviously, we have to take into consideration competing comorbidities and patients' goals for themselves. So through these genomic tests, we can have a prognostic evaluation and a predictive evaluation of what is the likelihood of recurrence from that particular breast cancer and how likely is chemotherapy going to benefit that particular patient with that particular cancer. So these are examples of the many predictive and prognostic genomic assays that we use in the clinic. There's the Oncotype DX, the Prosigna, the MammaPrint, EndoPredict, and BCI. Those are genomic assays that are RNA-based assays. So what we do is we actually take the tumor that we took out from the biopsy or the surgery, and we send it for a specialized RNA-based test. And that test actually looks at particular genes in the particular tumor, so very personalized, and it comes back to us with a score. The score is basically a reflection of the genes that we found, the gene mutations that we found in that particular tumor. Usually, the more mutations you have, the higher the score you get, and the more aggressive the cancer is. So I'm going to show you an example here with Oncotype DX. So Oncotype DX is one of the most common genomic assays we use. So it predicts, again, it predicts benefit from chemotherapy, and it also shows risk of distant recurrence. So we send that tumor for Oncotype DX testing. They do that genomic test. It's an RNA-based testing, and they come back to us with a report showing a specific recurrence score. And based on the recurrence score, we can categorize that particular tumor into 3 categories: low risk, intermediate risk, and high risk. And based on the risk category that the patient is that patient's tumor is categorized in, we can recommend treatment appropriately. So this is the study that actually showed how Oncotype DX recurrence score groups correlates well with distant recurrence. So as you see here, recurrence risk that belongs to the low risk group has really excellent survival and excellent distant recurrence, freedom from distant recurrence. So the blue line over here. And then patients who belong to the high risk group have a higher risk of distant recurrence, and therefore needs to be treated more aggressively. Again, this is the risk recurrence scores here. So as the recurrence score increases, again, the risk of recurrence increases and the benefit from chemotherapy increases. And this is, again, showing us the studies that actually looked at the absolute benefit from chemotherapy and how that correlated with a higher recurrence score. So as you see here on the far right, the higher your recurrence score, the more absolute benefit you see with chemotherapy. So how does this help with overall management? So if we look at Oncotype DX and we get a score that's low score or high score, if we're getting a low score, we avoid chemotherapy, and that's really avoiding side effects of chemotherapy, lost time from work, avoiding hospitalization and supportive care associated with that, and then a poor quality of life. So you're sparing the patient all these negative adverse events associated with chemotherapy. Whereas if you have a high score, we know that the patient is receiving actual life-saving treatment. So we're able to prevent recurrence, prolong survival, improve long-term quality of life by giving the appropriate treatment to the appropriate patient. So for sake of time, I'm going to skip over these few slides, but this just shows you that age is also an important factor to consider when you're looking at whether to give chemotherapy or not. So back to our case. So this is Miss K. She had an Oncotype DX score sent on her tumor, and it came back at 11, which is associated with a low risk of recurrence and no clear chemotherapy benefit. So she was given that news, and she was very happy to not receive additional chemotherapy. She proceeded to radiation treatment, followed by endocrine therapy treatment. So real brief endocrine therapy options. I'm sure everyone's familiar with the endocrine therapy options that we give in breast cancer. So in postmenopausal women, we give something called an aromatase inhibitor, which is the preferred agent in postmenopausal women. Aromatase is an inhibitor that aromatase is an enzyme that tries to convert other hormones into estrogen. And in women with breast cancer, while aromatase is an important enzyme for postmenopausal women to supply estrogen, which is important for the body, in women with breast cancer, we really want to inhibit that enzyme because the additional estrogen will actually just feed the cancer. So we give agents that suppress that aromatase enzyme in postmenopausal women. The other option is tamoxifen. And as you see on the picture on the right, tamoxifen actually blocks the receptor itself. So if there is estrogen circulating in the body, it prevents it from combining with the estrogen receptor on the breast cancer cell and feeding the cancer. In premenopausal women, really aromatase inhibitors don't work well unless you suppress the ovaries. So it is an option if you're suppressing the ovaries, but otherwise tamoxifen is the agent of choice. So the update I wanted to give here for endocrine therapy is really the extended adjuvant endocrine therapy beyond 5 years. So a lot of studies have looked at the benefit of extending adjuvant therapy beyond 5 years to a maximum of 10 years. And several approaches were taken in these studies, including continuing the same drug for 10 years, switching from tamoxifen to aromatase inhibitor once the patient turns postmenopausal, or just continuing the same aromatase inhibitor for 7 or 10 years. And this is a meta-analysis showing the end result of these studies. And as you see here, that in node-negative women, I highlighted the data in red. So in women that didn't really have a lot of node involvement, the benefit from extending the endocrine therapy is very minimal. So it was about 1%. As you see more lymph node involvement, we see more benefit from extending adjuvant therapy. So women with 1 to 3 positive lymph nodes had about 4% benefit from extending that adjuvant therapy. And then women with 4 or more positive lymph nodes had more than 7% benefit from extending adjuvant therapy. So really our practice right now is to recommend extended adjuvant endocrine therapy for women with higher stage disease and more involved lymph nodes. The other way to also predict late distant metastasis is by using the CTS calculator, where we can include the patient's age, their tumor size, their grade, and the number of involved lymph nodes, and it gives us a result. And based on the result, it gives us whether the patient is low risk of late distant metastasis or high risk. And obviously, if the patient is a higher risk for distant metastasis, late distant metastasis, you would recommend extended adjuvant therapy. So this is another way of personalizing their care by plugging in their tumor characteristics. So to summarize, who should consider extended adjuvant endocrine therapy? It's women with higher stage disease, so a woman with stage 3 disease, women who have tolerated treatment for the first 5 years, especially women who had started with tamoxifen, have become postmenopausal. I think it's important to give them an aromatase inhibitor, which is shown to be superior to tamoxifen in postmenopausal women, and probably not extend that for over 10 years. All right, so extended endocrine therapy also comes with its own toxicities. This was a really nicely written paper on how to deal with aromatase inhibitor induced musculoskeletal symptoms. So there are various ways I would recommend you read this paper published in by Dr. Arjun Gupta, and talks about various ways and interventions that you can do to help with skeletal symptoms. All right, moving on to HER2-positive disease. So I'm actually going to switch to a different case. So this is Mrs. L, who's a 43-year-old woman who had a 2.2 centimeter ER/PR negative HER2-positive breast cancer with 2 positive lymph nodes that were clinically shown to be involved with cancer. She is very anxious about her new diagnosis and asks you whether you would be getting surgery soon. So what's the next step for Mrs. L? So systemic treatment update for HER2-positive breast cancer. So patients with a tumor size of over 1 centimeter should receive a combination of chemotherapy plus HER2-directed therapy, trastuzumab, plus minus pertuzumab. HER2-directed therapy cuts the risk of recurrence in half for HER2-positive disease. As you see on the right, there's a big gap between women who received anti-HER2 therapy versus women who did not receive anti-HER2 therapy, showing a significant improvement in survival for women who received HER2-directed therapy. There is a risk of cardiotoxicity, but the absolute risk is pretty low. So benefits certainly outweigh risks when it comes to HER2-positive breast cancer. The other thing I wanted to touch base on is now we're using a neoadjuvant approach in HER2-positive disease, which means giving the treatment pre-surgically. So in the past, we used to proceed with surgery right away after diagnosis. Now we actually recommend a systemic therapy before surgery for larger tumors. And really the goal here is to first to control micrometastatic disease. So if there are little cells lingering around, the systemic therapy goes through your whole system, so it's able to kill all those micrometastatic cells. It helps shrink the tumor. So if someone's interested in a breast lumpectomy over a mastectomy, it makes that more feasible. And it also helps you assess the response at time of surgery. So when we give treatment first and then take the patient to surgery and remove the tumor, we actually can see how the tumor responded to the treatment we gave it, and understand whether there are resistant cells that did not die with the chemotherapy or anti-HER2 treatment we gave it. And we're able, based on that information, we're able to adjust the HER2-directed therapy based on their response. And we'll talk about that in a second. So I'm going to skip over this slide and this slide. I want to move on to Mrs. L, who agreed to a neoadjuvant systemic therapy approach based on the advantages that we just showed. She completed 6 cycles of paclitaxel plus carboplatin, and then she also got anti-HER2 therapy with Herceptin and pertuzumab and proceeded to surgery. At the time of surgery, her pathology actually showed 7 millimeter invasive cancer consistent with residual disease. So what is next for Mrs. L? So the fact that she actually had resistant cancer cells remaining in her tumor, it tells me that maybe those cancer cells are not responding to the prior treatment for a reason. And there are studies that actually looked at something called pathological complete response, which when we take the tumor out at the time of surgery, we look at the cancer cells under the microscope. And if all the cancer cells have actually dissolved and are dead at the time of surgery, we call that pathological complete response, so complete response to therapy. However, when we find residual disease, such as Mrs. L's tumor has had some residual disease at the time of surgery, it tells us that maybe there are some resistant cancer cells there. And when they actually looked at patients who had pathological complete response, in red here, versus patients who had residual disease in blue, you found that the survival of patients who responded really well to therapy was higher than patients who had residual disease. Based on that, we actually had the Catherine study. And the Catherine study looked at, they took those patients with residual disease, HER2-positive residual disease, such as Mrs. L, and they randomized them to receiving another treatment, HER2-directed treatment called TDM1, which is a combination of a chemotherapy and an anti-HER2-directed therapy, versus continuing just the anti-HER2 therapy they were on before they had their surgery. And they found that switching up that drug actually did better for these patients. As you see on the right, there's a gap there showing that the TDM1 did a little better than receiving the same therapy you gave in the neoadjuvant setting. So based on that, we actually changed our algorithm for treatment of HER2-positive breast cancer. So if you look on the right here, for patients who have a larger tumor, who got chemotherapy and anti-HER2 therapy, who went to surgery, if they have a pathologic complete response, they continued their Herceptin and pertuzumab, which they received neoadjuvantly. Whereas if they didn't have a PCR and they had residual disease, they switched to something called TDM1 based on the Catherine study. And I'm getting a signal here from Tim that we should be wrapping up. I'm sorry, we have a lot of slides left to cover. I wanted to talk to you a little bit about immunotherapy and triple-negative breast cancer as well. So I'm happy to do a follow-up lecture on this to continue the rest of the slides. I wanted to show a little bit more about the treatment of triple-negative breast cancer and how touch base a little bit on surveillance, but I'm happy to also provide those slides to you. That way you can review them on your own and then continue a follow-up lecture. I'm sorry, Tim, my raspy voice didn't help with time, and we had a lot of slides to cover, so I guess we're gonna have to wrap up before we finish the slides.
Oh, no apologies needed whatsoever. We are very appreciative. This has been great, and we would love to have you back. So we'll plan on that. I'm sorry we didn't have more time. I do know that a lot of our attendees are using their lunch hour and need to get back to clinics and that sort of thing. So let's go ahead and we'll plan a follow-up, and we'll look forward to that. Are you ready to, if we have a few questions, would you be ready to go ahead and take those?
Oh, absolutely, absolutely.
Okay, that would be great. Let me progress to the, and I think we had one that actually came in through the chat that I can share in just a minute. Let me get to where I can go ahead and share the questions with our audience. Yeah, I think we have
I see a
whole
question.
nother lecture here.
Yeah.
You want to go ahead and take that one in the chat about dense breast tissue? Okay, that would be great.
Yeah. So for those with denser breast tissue, do they tend to get called back further for more testing, is the question. And will they be called every year versus every 2 years just to check, since pictures are difficult to differentiate? So usually when you have denser breast tissue, the radiologist will pick that up and they would recommend additional testing if needed. So a lot of times we actually complement our mammograms with ultrasounds, sometimes MRI, even if the patient's young and they have a lot of denser breast tissue. So the radiologist and your oncologist will actually be able to recommend a specific plan for your specific breast tissue. However, I do recommend yearly testing for women with denser breast tissue, just because of the things we pointed out, which is difficult to catch those cancers. And I do recommend 3D mammograms if available. So tomosynthesis for patients with denser breast tissue, if available at your institution, for us to be able to pick up those abnormal lesions a little more easier.
Great, thank you. And we had another question. Is there a genetic/molecular factor that has been found to be the cause of increased worst cases of breast cancer in
That
Black
is a
women?
that is a great question. There are many molecular factors associated with worse prognosis in Black women with breast cancer. We actually, when we talked about the molecular subtypes a little bit, we at UNC, Dr. Lisa Carey had led a big study years ago showing that Black women with breast cancer have more luminal B and basal-like subtypes of breast cancer, and those tend to be associated with more aggressive breast cancer subtypes. So we do know that there are molecular features that have been identified to show a more aggressive and disease in Black women with breast cancer. Now, our goal is to find a way to sort of overcome these molecular factors and tailor treatment accordingly to improve survival in Black women with breast cancer.
Thank you so much. I want to let our audience know if you were here from the beginning and you need to leave now, we understand. And as long as they were here from the beginning, they'll still get that full credit for the lecture. But we have so many good questions rolling in. If you can stay a couple of minutes, and Dr. Abdou, if you have just a couple more minutes, we'll take just a couple of more questions.
Absolutely,
All
absolutely.
right, thank you. Whoops, there it is. Is there any data for the role of hormone replacement therapy and potential effect on hormone receptor status for breast cancer?
Yes, so there is data showing that getting hormone replacement therapy for over 5 years, so getting it for a long period of time, can increase your risk of breast cancer. So I usually recommend that if you're on hormone replacement therapy, probably keep an eye with your primary care provider or gynecologist on the length of your therapy. Try not to exceed that 5-year mark. And then if you were ever diagnosed with breast cancer, I would highly recommend staying away from any hormone replacement therapy moving forward because it would increase your risk of having another breast cancer.
Right, and here's an appropriate follow-up question. Do topical estrogen therapy fall into the same risk as oral?
That's a great question. Topical estrogen therapy does not necessarily fall in the same risk category just because systemic absorption is less with topical estrogen therapy. However, we do also tend to stay away from topical estrogen therapy once a diagnosis of breast cancer is made, specifically if it's a hormone positive breast cancer driven by estrogen. We tend to avoid topical estrogen therapy. If you're not diagnosed with breast cancer, then I do not see a reason why topical estrogen therapy would be a problem. I would highly recommend it after discussion with your primary care provider and gynecologist if indicated.
Great. And then we'll take this last question. I'm assuming this is a follow-up to earlier. Does this go for estrogen and progesterone?
Correct. So if we're talking about hormone replacement therapy in particular, yes, it goes for both estrogen and progesterone. Particularly estrogen is what we're just continuous, non-interrupted exposure to estrogen is actually what drives the best breast cancer.
Terrific. Thank you so much. We'll go ahead. Let's just have a few closing remarks. We want to thank the University Cancer Research Fund for the important funding that comes through there and through the state of North Carolina. We want to thank the UNC Lineberger Comprehensive Cancer Center and the team here at the UNC Lineberger Cancer Network. That's Veni Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh. Song Backroads was written and performed by Don Poe. We